So we're just here to take a moment to speak about working in the region of the abdomen. Now, I have done a video in the past speaking about a paper with respect to the clinical efficacy and diagnostic accuracy. I believe that's the appropriate title of visceral osteopathy, or the visceral methodologies within osteopathy. And the paper essentially suggests that with respect to the claims that visceral osteopathic concepts make, that there is no diagnostic reliability or clinical efficacy. That doesn't necessarily negate the fact that there may be some positive effect working in the abdominal region, right? So working in the abdominal region through general palpation, it will be suggested that you will not accurately identify any organ structure, especially if you're considering the fact that you have the skin, the layers of fat, depending on the person, how much they may or may not have. The abdominal musculature in some people is quite well developed, in other people not as well developed. But then you have fairly obscure structures deep to that. They are not all the same shape in all people. Odds are that you don't have a patient with situs inversus, right? So the liver should be generally over here, the stomach and spleen generally over there, small intestine somewhere in here, colon wrapping around it, going forwards and backwards depending on where you are. These are all realities. However, if you are able to accurately and clearly identify an abdominal organ, you're probably in a situation where your patient is in danger, right? You also want to consider rebound tenderness. So if at any point you push into the abdomen and you let go, and that's when the patient feels pain, then you have a dangerous problem and you should refer out. That patient should seek essentially emergency medical care because there's probably a visceral pathology. Another thing that can lead to concern and consideration is if we bring the patient's knee up towards their chest, and as we do that, they feel heavy discomfort in the abdominal region, because when you do this, what you're doing essentially is crowding everything. So you are putting some external pressure with the thigh onto the abdomen, and you're causing things to crowd and push against each other. And if they have a sensation of pain, then there may also be something there. So as far as safety concerns, heavy duty pain, sharp pain, quick pain, those are major concerns. That being said, the abdominal wall has some musculature. You can kind of test soft tissue motion perpendicular to fiber direction. So depending on which fibers you're talking about, if somebody's speaking about pain or a lack of motion in this region, you can investigate it. Just simple palpation, simple pressure on and off, moving side to side, again across fiber direction. You can test in through the lower ribs, so the common costal cartilage, the lower, more or less the lower 6 ribs, or really 6 to 10, depending on the person, 11 and 12. If you're going to touch ribs 11 and 12, they're often quite tender in most patients, and attempting to find them accurately, in the act of doing so, you will probably make the patient feel pain. That all being said, what we can consider is the relationship of motion between bony elements. So between the inferior costal border, the inferior costal margin, right through there, and through the iliac crest, we can assess motion. Now, the challenge is that the best place to work on the abdomen is often when the patient is in a supine position. The problem with testing the relationship between the ribs and the pelvis, or essentially the lumbar region as proxies, on the top and the bottom you've got these bony structures or these bony cages. The problem becomes to test those motions, or the relationship between them is limited by being on the table. So as far as rotation is concerned, right, if I do this, that's nowhere near as far as the patient can rotate. That being said, it doesn't mean that I can't assess tissue tension, tissue texture in this region, right? So the same things apply using a long lever, a short lever, or a mixed lever, right? So we can work in through the abdominal tissue in this fashion, right? Pulling towards us. Wherever we happen to find a alteration in tissue tension in the abdominal region through palpation, and the palpation kind of pushing in is essentially a motion test. So all of this kind of coalesces together in varying ways. As far as an organizational structure, we would follow the normal organizational structure that we have with respect to assessment. So macro identifies micro, patient active preferably before patient passive. In a situation like this, it doesn't really work all that well to go patient active. But we just want to speak about the fact that as far as general MSK complaints, right, abdominal tension, abdominal pain, as long as that abdominal pain doesn't show rebound tenderness, or when compressed by the leg, or one leg or both legs, that the patient doesn't experience significant pain, there is value in assessing the abdominal region and working on that MSK complaint, whether direct or indirect, and we've talked about how to choose those things. So to go direct if there is no pain upon movement. If there is pain upon movement, again, barring a red flag, then we can go indirect. But what we want to be very careful with is saying that we're working on an organ, right? So just because my hand is here doesn't mean I am actively or provably doing anything to the liver. I may not be. Is it possible that I may be? Yes, it's possible, but at this point we don't have evidence to suggest that we are. So just overall, the opportunity to have the patient on the table and speak about these concepts with some very, very minor demonstration. Again, getting into the abdomen, you can use the ribs as a short lever, just messing up my words because I'm in the region where the liver lives. We can use, again, as another short lever, the actual pelvis. We can use the leg as a long lever. It's possible that we could use the arm, but it's unlikely in a supine position that we would get much going on. We can use mixed levers, so directly on the abdomen using the leg as another lever, directly on the abdomen using the pelvis as another lever, so short lever, long lever, together mixed leverage. These are all options that we have, but we'd have to have a reason to investigate, and the reason to investigate the abdomen would be that the patient told you that there was something wrong or brought up a point of concern. So all of those things, again, we just take a few moments to have that discussion so that you can consider it. But keep in mind that as it stands, there's no evidence to suggest that working in the region of the abdomen does what osteopathy classically says it does in the form of visceral osteopathy, because we have a fairly strong meta-analysis out there that I've already pointed to that says that the claims that visceral osteopathy makes are not accurate. But again, that does not mean nothing happens when we work in the region of the abdomen. There may be quite a bit of benefit for working in the region of the abdomen, especially with respect to motion problems, which we objectively and observably will improve, as well as essentially subjective complaints of pain or discomfort.